recorded and it will be available for viewing up to 3 months following the conference using your CVent login. So good morning and welcome to the last day of the clinical practice track. Today, again, we have Ms. Ketcher, Christina Peters, and Julie Sword. Starting our session with best practices and implementing the CHAP from Northwest Portland and Southern Plains. A little bit of a bio for Mrs. Ketcher. We have, she's a retired public servant from the federal government Senior Executive Service of the IHS in 2017 after 30 years of service with the agency, where she serves as the Area Director of the National Area Indian Health Service. Martha is a Cherokee Nation citizen and a native of Oklahoma residing in Tennessee. She earned her BS degree at Northeastern State University in Oklahoma, and an MBA Healthcare Administration at the University of Phoenix in Nashville, Tennessee. During her service in IHS, she received numerous awards and recognition. The most notable distinguished award was the HH Director Donna Chalala from the Advancement of Self-Governance. And Martha served in numerous capacities like accountant, budget officer, finance director, governance agency lead negotiator, deputy area director, to ultimately the area director. As area director, she served 30 tribes across 14 states and was instrumental in establishing 5 health clinics across multiple states and successfully obtained multi-million-dollar appropriations for new tribes. Post-federal retirement, Martha served as the USET THPS director. I didn't know that. Martha is also the owner and founder of Yona Consulting Services, LLC, where she continues to use her experience and expertise in leading her team to assist Native American tribes to transform vision into action. In 2018, post-federal retirement, she was appointed as the Cherokee Nation Executive Director for Community Service under the Baker-Crittenden administration and continues to serve her tribe under the Hoskin-Warner administration as the Senior Advisor for the Tribal Health External Operations. In this capacity, Martha was appointed to the National Community Health Aid Program Tribal Advisory Group, CHAPTAG, along with serving as the Tribal Self-Governance Grant Project Manager, TSGP. She is wife of Ralph W. Ketcher of 34 years and a proud mother of Sydney and Kyle Ketcher and 2 grandsons, Yona and Waya Ketcher. Thank you so much, Mrs. Martha, for being here. Mrs. Martha Ketcher, the floor is yours.
Thank you so much for that introduction. Yeah, a long paragraph when you've worked as long as I have in the system. So I shouldn't have ate peanuts before I got up here because now I feel like the nuts are all over my teeth. Please forgive me if I'm smacking around. Past 2 days, you've attended some sessions on CHAP with Christina and Julie. Some wonderful presentations. I've sit in on portions of them, but I've heard them before. And that's why I always bring, if there's opportunity for CHAP, these are the ladies you want to teach and to talk to. I'm so proud to be associated with them. I wanted to talk about, next slide, please. What those best practices were that they have provided. So we'll talk about that and some opportunities currently available with CHAP, the National CHAPTAG issues, funding, and we'll have a group discussion and we'll talk about advocacy. We have a separate set of slides. If we have time at the end, we'll go through those slides where we talk more in the granular details of the program. But my presentation will be at a high level. And right here, the best practices for Northwest Portland. Oh, okay, I can do this. I say, okay, thank you. I'd like to hear what were some of your takeaways from the presentations anywhere in the room.
The complexities of the regulatory barriers to overcome. What's the big takeaway from?
Excellent. Good one.
Also, just one point, not everybody in here probably heard the first two presentations.
Okay.
So for those of you who have not heard anything, you came to the right place. Martha's gonna update you on the previous two. So we're gonna be caught up. We have the whole team here, so it's like Voltron. They work great individually, but together, you know, they're indestructible. And so any questions that y'all have to come up, feel free during the presentation to ask anything. If you have a low knowledge of chat, if it's 0 to 1, they'll be able to catch you up to 9 to 10 in one session. So.
The collaboration
Thank you.
really honed in with these, building those partnerships locally to building the relationships with the universities, their efforts in trying to shape that curriculum, that academia space, that they're working collaboratively with the universities in Portland, Oregon, and Oklahoma City, or Norman. That's what was one of the things that I really enjoyed working with them in the Oklahoma collaborative. What I like about Julie's doing in Oklahoma is she brought all the grantees together. So collectively, they're working together, have monthly calls about what they're doing and how they can achieve their goals within the program. And just there's just strength in numbers, knowledge, and strength and power in that. And that's actually USET's motto, right? There's strength in unity. So bringing those tribes together in Oklahoma and Oregon and bringing all of that together was really the advisory groups that they formed to help advise in each of those 3 disciplines. There's the dental, behavioral health, and the medical piece of it. One of the things that probably are forming, and that is in the works, is that partnership with the states. We had 14 states that I worked with in my career. That was not easily achievable. We relied on where those federal service units were to help us build that bridge, build that relationship. But when you're specifically in a state like Oklahoma and Oregon, you have that opportunity to focus on those state representatives, because you want to build that relationship for that state plan amendment that's going to need to occur. Although we are sovereign nations, we have to build that relationship with CMS to start that reimbursement, because these new provider types are reimbursable. I don't know if you're there yet, but I know you're working on it.
So we work in Oregon, Washington, and Idaho. In Washington, they just approved our dental therapy spa. But that was after we took them to the ninth circuit and won. We did that in 5 years. We submitted that bond 2017. And then we have submitted state plan amendment in Oregon and the state plan amendment for behavioral health aides and community health aides and the other levels of dental health aides. In Oregon, they passed statewide legislation for dental therapy. And so that covers our dental therapy providers, and they did a separate state plan for that. And then in Washington, we are just now since we just finished this whole thing with the ninth circuit. We're just now starting to work. We started it before, but we were kind of waiting because we didn't think it would take so long for the dental therapy spa. And then in Idaho, they're like, we don't need a spa. And we're like, you guys are wrong. So we're working closely with tribal people.
So you're probably the first in the lower 48 to get that far. I know that in Oklahoma, we were planning to have CMS to come and speak to the tribes, and I was looking forward to that conversation, just to learn that process of that state plan amendment to start that reimbursement phase of it.
There's a lot of education with that needs to happen with CMS and also with the state, because state plans they're so tied to like state licensure and state licensed
Mhm.
providers. And so there's a lot of nuance to that, and having really strong state partners, as Julie was talking about in her last presentation, has been key to navigating that space and being able to add things like this concept of federal certification, but they really focus on that relationship between that state licensed provider and your federally certified provider. And that for us has been the, well, we'll see, but that is what our SPA experts in Washington and Oregon, the SPA experts there, believe will be the fairy dust that helps CMS understand what we're doing.
Yes, I think that, having CMS at the table in your national meetings on the agenda is going to help. Just to go back a little bit, she mentioned that I was a part of the CHAP as a Cherokee Nation rep. I served on the national CHAP tag. And then I've left the Cherokee Nation since then in March and focusing on my company of Yona Consulting and serving tribes in a more diversified way. And doing so, I met with Kiki, our Mr. Carroll, the executive director of USET, and told me I wanted to stay engaged in CHAP. That it was a new program, relatively new. It's not that new, it's just slow to take off in the lower 48. And he was happy to have me to assist in that space, and so I'll be a technical advisor in CHAP. Not a primary, but a technical advisor. Okay, that space there is one of the biggest benefits, I think, not only to the patient about having that community rep in your area, and it's also those new provider types at a lower cost than a high cost provider. And then to have that new provider type services be reimbursable from CMS. The current opportunities now, oh, I have this. Tribal Assessment and Planning Grant is open right now. And the purpose of that is to conduct a feasibility of implementing CHAP in the community. And the amount that's available for that is 250 to 500,000. The deadline is August the 7th. I encourage you in the next 3 days to go home. And there will be 3 to 5 awards. It's a 2-year period of performance. The IHS appropriations for this is, as you know, is 2 years. I think advanced appropriations is in the works now for 2024. So a lot of good things happening in the agency, advanced appropriations, and even without advanced appropriations, the tribes have what they have an exception apportionment, where the tribes do not have to wait on a continuing resolution to get their full lump sum funding. But right now, CHAP is in the 2-year appropriations, and this is the feasibility of, this is where you would want to start. The TIPI is, sorry, this is the place where you want to start. Here in the TIPI, it is implementation. You've gone through the feasibility, now you want to implement. This grant will help provide resources to do that. The awards are anticipated to be between 900,000 and $1 million. The deadline on that is passed. 3 to 5 awards. It's a 2-year performance period as well. As far as national CHAP, the work that's being done with position descriptions are anticipated to all be completed by November 1. Does that include all 3 discipline types, or is that just the headquarters infrastructure?
I believe that's just headquarters infrastructure. They haven't even started on the CHA job description. They have for BHA, they have a job description that they're using from the existing job description, and for dental therapy, I think they just got that done, but they don't have the other levels of BHA.
So the program is a $5 million program. Off the top came some resources to help headquarters to build the infrastructure to administer the program. And they've recently filled over the past year some of those positions and lead positions. So it's a very green team, in my opinion. The tribes are having to train the leads on the tribally operated programs. And that was very evident in the last meeting that I attended last week. The records management, December of 22. It needs to be updated for a new target date with the lead of Dr. Sixkiller. SORN, System of Records Notification. The IHS reviewed this in July of 23. They're 90% there. The next step is to publish this in the Federal Register. There's some privacy policies that apply to this. So the act requires that they go to the Federal Register for a 30-day comment period. Once that notifications come out for the Federal Register, I encourage everyone to comment on those. But it is just a notification that the agency will protect the privacy of everything that's in that system. It's a new system, so they're having to run it to the Federal Register. The policy circular 20-06, the target date to have that completed is April of 24. And the certification forms, December 31 of 22. And
They missed that one.
they missed this deadline, so they're going back to revisit this date. It is a lot of conversation on these certification forms, and it's certainly the federal bureaucracy at its best in developing these forms. It has to go through so many layers of review, privacy, records management. OMB has to approve the form, then it goes to HHS. So it's a lengthy process, and it's a form that they have taken ownership of because of the federal inherent interpretation that they're making. Privacy regulations hasn't been updated yet. There's a new target date for it, correct? And the subject matter experts will be working around those regulations. The national standards and procedures, they're temporary. There's some that's temporarily being used in the Portland
Yeah,
area.
they say they're gonna use those
They're going to use those.
for dental and behavioral. They're not rolling out the CHA portion yet, even at the national level, which is frustrating.
Is that, did you use a lot of Alaska's?
We started with Alaska's, and so ours is, it meets the baseline of Alaska, and then we updated some of the language to be more with, has a lot more around historical trauma, health equity, and those kind of pieces, and then we just went above, in other places went above Alaska in terms of what our really wanted.
So this is the work that will be done by the subject matter experts on the national standards and procedures. And that is still in formation. And every venue that we have been in, we've advocated for tribes to submit subject matter experts from your tribes. We've presented together at Tribal Self-Governance Advisory. We've presented at the NIHB and solicited for tribes to put names forward or areas to put names forward for this advisory group. The subject matter experts are at the tribal level. And I'm anxious to see how that forms up in Oklahoma. Do you have those positions filled for each of the disciplines?
I think really.
Well. For fire. No, I don't believe that we have anyone currently from Oklahoma. I do know that there had been a nomination sent out for the National Certification Board. And I'm not sure if that's a subject matter expert or if it's just, an area representative for the national certification, which I believe that is, I believe that's the case. But her area of expertise is behavioral health, so. And actually, it's Ashley Johnson from Kindergarten, probably know her. Okay.
She's with the behavioral health program.
Yes, yeah, so she has been the one and only one nominated and.
Okay, so that's the national certification board, but
Yes.
within that will be these work groups of subject matter experts for each of the disciplines.
Yeah, that's
They-
a work group of the tag.
Okay.
The subject matter experts coming in, and there's supposed to be one from each area for each subject matter.
Because there'll be these area certification boards.
Yes, and on the certification board, there should be 2 nominations from each area, federal rep and tribal rep. And in the best case scenario, that tribal rep also serves on your area district. In the best case scenario, once you have it.
Okay. So that's going to establish that the standards and procedures will establish the baseline, the scope of work. And the minimal standards and training requirements. They'll help outline the process whereby standardization is applied across the national channel and the various provider types. And the National Certification Board is October 23. Is that still a good date? For
For the National Certification Board, I don't believe that they have to do tribal consultation on that document and. You've seen the.
it's going to be moved back.
Yeah, it's gonna be, you've seen the charter, you know that they can't put that out.
So in addition to that is the chat wrap tool. It's a work group that's been working with minority health. And a group from there that's been establishing this tool. And why don't you talk about the chat wrap tool? Have you what your experience is with it?
Hey, I've just seen the draft that's been released through our, through Gene Ferry, through our national, chat tag. And so the draft seems pretty incomplete and pretty high level, but I don't have much. That's all I have for that.
Yeah, I can talk a little bit about it. I mean, the purpose of the chat wrap is really, so it started, gosh, probably 2018 or 19, and it was a grant through the Office of Minority Health, and they contracted with a contractor. I don't remember who, but it was a contractor. Well, I don't remember the name of the contractor right now off the top of my head. But the woman who was doing that work is a Spokane tribal citizen. She had some experience with CHAP, and the purpose of it, I think what Office of Minority Health and the CHAP team were thinking is that it would be a great sort of starter manual for, oh, I want to start a CHAP. This is what I need to consider, which is why it feels incomplete, I think. Because it was informed, you know, it's like you don't know what you know, and so it was informed probably 2 or 3 years ago, and then they just spent 2 or 3 years going through, so it's already kind of outdated, I think, because since then, you all have done a significant amount of implementation, we have done a significant amount of implementation, and there are a lot of ways where we were, oh, we weren't anticipating that. And so there's probably a lot more that could be included for chat wrap, but if you've never seen anything about chat ever, the chat wrap is a great, like, kind of overview starter place to look at it and then to get more information.
And then to start to shape it to fit your communities. I think it would be a good tool for those who are even applying for the feasibility part of it. And
It's really a great tool if you zero chat information. It's a great place to start.
okay, the National Chat Tag issues. The issues we've taken with the formation of all of these documents. Primarily starting with the charter. The issues that we see that are lacking is that government to government relationship there. Roles and authorities and responsibilities. It's a very paternalistic approach. They will go out for consultation. We brought to their attention some of the things that really just glared at us that we'd hope that they would change. For example, we more or less demanded that we have a tribal co-chair and that it be structured. But like other tribal advisory groups like TSGAC, they have a tribal co-chair. And when they have national meetings, it's that tribal co-chair that's leading the meeting. And because they're the ones that have they're the boots on the ground and have the direct experience with the program. So we're really pushing that. We asked for that change to go in prior to consultation. The other is like veto authorities. The federal chair would have that veto authority, and we're saying not without the tribal co-chair's signature. We brought up other points in that, but in the event it goes out without those changes going in that we've requested, you'll have an opportunity to comment in the tribal consultation process. Please hone in on those. And if we need to share in the USET region, some talking points in regards to some points to make in regards to that consultation process, I'm sure that USET will roll those out, and I will certainly help prepare them. And same thing in Oklahoma and Oregon. I know that these ladies are going to be all over that.
I think we'll all work together, just because it would be really powerful for a reminder to IHS at multiple areas saying you can't give the federal government this much power over tribal.
Okay. Yeah, I think so too. The funding mechanisms, you have a lot of discussion, grants versus ISDEA. Right now, they're funded through grants. So there's a lot of administrative requirements that go along with grants. It's competitive. The funding expires. Whereas the ISDEA, it's available until expended. It does not expire. Tribes get contract support costs on top of that when it goes to the ISDEA. Those are additional resources for the tribe to administer and manage that through the ISDEA. The thing with the grants, I think that the agency was in, the position that they are in is they need for the focus to be on CHAP and the funding to achieve the funding goals with the dollar amounts that they can award through a grant is more focused on CHAP. Whereas if they roll it through an ISDEA, the tribes have authority to rebudget, in the ISDEA. So it may not be a priority at different tribes to launch a CHAP program. So for the time being, I think they felt like the grant was the best mechanism. But also for ISDEA, it has to be identified as a program, function, service, or activity, those PFSAs. And when it goes as a PFSA, I always get those mixed up. But there's some downside to that. That puts it at risk. And I've explained it in the chat tag a little, in that when it's available as a PSFA, that it can be broken down into tribal shares. Tribal shares means that everybody gets a piece of a little bitty pie, and you can't reach your goals with chatting that way. Unless they run it through the ISDEA. I've asked this question before to the director. Can this be added to the ISDEA as a non-recurring program fund, as with OEH&E resources? Those are non-recurring. They run a formula every year. Whereas I just think there's room there to explore ISDEA without putting it out to multiple pieces. It'd still make it competitive if you want to apply for it, but funding just channels to the ISDEA. I would still like to have that conversation. The federally inherent functions has been another issue that TAG has raised to them. They did this without consultation. They identified functions of the chat process as a federally inherent function. Example is that certification form.
Collection and storage.
Yeah, collection and storage of data. We're saying tribes collect data all the time. They store data all the time. How many clinics are across Indian country? They're storing data all the time. How is that a federally inherent function? And, still no response to that. I was maybe out of chat tag for a couple of months, still no movement on that. And then the certification forms, I just explained earlier in that, with the process that it has to go through, to ensure a privacy and OMB approval for new forms. The chat funding it's a $5 million program. The primary purpose was to implement CHAP into the lower 48. Alaska's been doing this since,
For IHS, or,
in Alaska.
oh, Alaska has been doing it since the sixties, but they started getting funds, I think, in 90.
So the 23 grants will be funded with FY 22 funds, because there's a 2-year appropriations, which extends the life of the funds. The grant is 1.5 million. TPI grant is 3 million. And that they've made some transfers to Portland and Billings for the area infrastructure and certification boards. You don't get the certification funding. In building infrastructure, the areas do not get the certification funding until you're actually ready to certify. Is that correct?
That is correct, but it's the wrong way to do it.
So they could even certify. Portland had,
Well, and that's the policy as well, because Portland area, we are ready to certify, we've seen it over. The Billings area is not ready, but even without being able to certify, they're sending the funds to our board. And honestly, to set up the board, you need startup funds. And it's not very much money, it's like $150,000. So it's enough for those startup funds, and they should be getting sending to all of it.
yeah, that's the wrong approach. I agree. To wait to send the funding to the areas until they're ready to certify, that's too late. Now you're gonna have providers sitting there waiting to be certified because the board hasn't even been formed yet. But the funding hasn't been channeled to them to form those startup. So there's issues with that. The grants updates, there's no cost extensions for TAP and available, and no cost extensions for TPI grants. After all grants have been closed out, any unobligated grant funding must be returned to Treasury. So, when you get the funding in the grant, that's the other downfall to it. Whereas as the ISDA, it's available to the tribe. Budget formulation is another area that we need to advocate in with our area of reps with budget formulation. I know that the USET area has a really strong representation on the budget formulation. So there's language that we can help formulate to help strengthen this. There's like 20 million that's been requested in the 24 appropriations, 20 million. And we asked, what is the justification that's used for that 20 million? And I did not get a very good response. It was more like there wasn't any language developed. And I'm thinking, well, then no wonder we keep getting overlooked because we don't have the language that supports the request for 20 million, 24 million. We have to strengthen that. And this is the place to start.
And the Portland area tribes through budget formulation of that, we've been asking for 60 million. We've been asking for 5 million per area.
Okay.
But we, and we have a pretty good justification, we put it in a few different line items as well, to say, hey, for the education, and we want the education program separated out because they're more expensive, but you know, it's hard when one area is advocating for something, we really do need a more coordinated effort.
So here's where I'd like for us to get into some groups and to answer these questions. You can have identify somebody as your recorder and report out to the groups to answer these questions. So if you could get in, I don't know, is there enough for 3 groups? Three groups or two? Two groups. Let's just do 2. And if you could, if 2 ladies could join those in the back.
We'll break up.
Oh, yeah, yeah. One on each side. Maybe just turn the chairs around or come up and join the group. Let's respond to these questions. How many community health aid providers do you anticipate are needed in your community for each provider type? The second question is, identify systemic barriers that prohibit the complete integration of staff into an existing healthcare system. The barriers should be related to clinical infrastructure, workforce barriers, certification of providers, training of providers, and inclusion of culture in services provided by a CHAP provider. And you may have. And have I gone over? Is anybody monitoring my time? You got 20 minutes left. 20 minutes left. Okay, that's good. So take 5-10 minutes. When you're finished, just let me know. There's 2 more questions on the other side, which estimate staffing needs to implement a chat program and plan partnerships to address the barriers, including reimbursements, training, education, clinical infrastructure, implementation costs, and determination of system integration. So right now, start with 1 and 2, and tell me when you're ready for me to switch to the next slide.
Yeah.
Yeah.
I think a lot of us have done this, and so we don't know the answers.
You know, I read that. In program, whether existing programs and what your just general staffing needs would be in areas of community health, like.
So like, our programs, so usually whenever chat extensions happen.
What does the full staffing look like for you? That's a good place to start, because they
We see
do
an outcry.
those types of, so if you had.
Thinking that
We'll start with
chat was going to
three
replace
dentists needs to
charge
be staffed up.
or
You could
money
probably
from
do
that
one
line
dentist
item,
and 3 health aides.
chat.
And then you would
that's
be
not the
fully
case.
staffed,
They're
their
completely
dentists
separate.
would oversee your health aid
CHR
staff and then your health team, they would take care of all of your primary
For sure, from what
care and all of the things
for
for
us
us
too,
to practice, and then the dentist.
CHR is really doing like a baseline.
And that's
the
kind of the part that you should be
direction
practicing.
as we go to
You
build.
start with,
So
what do we need in
it's-
our clinic?
It's, you know, I guess.
So what do you need in your clinic?
Curriculum, they can let their own version, that their services are reversible, and then giving a pathway for CHRs to go to the next level, or the primary care, like the community health aid, or CHR going into a dental health aid, or behavioral health aid, right? And so it's actually, that is, adds to the progress in a lot of areas. And I think that's, when you're starting off, that's kind of what we're doing, looking at the HR infrastructure and how that's been done, and how we build on it to then provide a career path.
And that's what, you know, Lemon Nation is looking at that right now. So they're one of our tribes in the northwest corner of Washington, and they're really starting out their elder population to provide care. The big question around sending, because you could send a health aid team, community health, behavioral health, well, physical, behavioral, and dental health, and you could have them as like a traveling group doing home visits and things like that. And then they can run into problems around that, like what starts CPR, how do you get, and they really made it hard because that's such a good idea. It's so much less expensive to care for your elders at home, to keep them at home as long as possible, but they can stay. And so, you know, we're a couple of years away from this, but we're starting to wonder if we can train the teams to do it. Can we then maybe get a Medicaid waiver to try it out and see how it works? And so that's what we're working on with our state, but that's like, first we gotta get the providers trained. We've got dental health aid, so Lemming has dental health aid therapists now in their clinic. We've got 2 of them, and then they have a couple of behavioral health. So for example, in 2024, we're gonna start community health instruction. They want to focus them on that. So ask me again in 3 years. I'll tell you how. But there, you know, another thing about it, I mean, about what your needs are.
So if you're looking at how many,
Think about it in terms of provider types that you already
you
know.
know, let's just,
And then you can then kind of say, then
let's
it's
just say primary
easier
care.
to answer.
How many health aides, community health aides, population with a pretty robust, like CHR program.
I might sit Frank for 1 day a week.
It's
And
very
there's,
rural.
like very natural.
Yes, yeah.
Ours was, and they even had to scale back 100 miles. We were nice with, home care, like home care. And they were like, no, we gotta send those out, you're just gonna see routine diagnoses. People weren't getting in. Somebody called me this morning and said, I missed my appointment, do you want me to try to get back in, because now we're into. So.
I think it depends a lot on, it's like when you're looking through like a chat, right, it's sort of extensions of providers. So, you know, like, health aid is gonna be an extension of the nurse practitioner. So a lot of, some of the ways. that we're looking at it is what
So they
are-
work
what are-
under.
what are they-
Without the doctor.
Where you.
That's pretty good
And
relation.
give the town, you know,
Not
the town that's 20 minutes
You could
away.
theoretically
and they're the
expand the
supervisor
scope of practice
position.
to
You
include
can have
podiatry, not maybe not at the doctor level, but you
rural
could
areas
look at
where
that
people
scope of practice
don't
and
want
decide like
to,
what is.
you know, reside
Because
or
the way
land.
that the
So,
health education works is
you
that
know,
they
in
provide
that
the base
case,
level of
what
training
would
and then
be
go back to
assisting
the clinic
with
and then
sending them
mentorship
to,
and
Ketcher,
mentorship within their scope of practice more.
Yeah,
What
they
I'm
could,
hearing
yeah,
is,
yeah. You know, another thing that we're kind of working through ones, and I think they were talking about, Dr. Hill was talking about that this morning, is like.
the community health.
You know, you
aid
can't,
practitioners, just to
like,
give you a sense of
providers
it,
here on someone's
like,
own,
community
it's
health
like, we have to do it, it's like four walls
So
of
what
clinic,
is
and
it, a
so.
well-worn
The beer, so that's another very, this is like, how can we, when we're deploying these, health aid,
a lot of that care
because health aid is, it's part of.
they
Growing
they
our
generally
life, so it's
don't,
really
but
hard
they
to-
also like
So how.
they
how
are
do we
also
see
the
that these
visiting
health aides that
advice.
are
Like
in
all
their-
this is
that are in their
really
communities,
really rural and they operate on
you
a
know,
hub
if
and
they
spoke
have
model. And so like all the women who
clinic, that's
are
like-
pregnant
that's
eventually
issue
make their
where
way
they're
to
not
Anchorage
able
and
to do
and then all of the
visits and
what
things
they
outside
spend
of-
and they
of the
spend
clinic
millions of
wall.
dollars a
So,
year in Medicaid program flying people in
So
for
I think
acute
that's
care.
where, you know.
And what the health aid program does is they reduce the cost,
But when you're looking at.
in their
how many
home community.
providers
So
you
they're
have,
not,
I think a
they
lot
don't
of it
do it as a
depends on,
house to house model, they do it
Where
as
you
a,
at?
their
where you
clinic is now
have-
staffed with community health aid behavioral
What
health aides and
infrastructure
mental
do you
health aides, and
have
they're able to get that primary
right now?
care, but they're also.
Because if you had,
responders.
if
So
you
if
had a
you,
physician.
roll
that
your
you
snow
could
machine, they're gonna be the
use
ones
as
that
a
show up on
supervising
the
physician
ambulance snow machine
20 minutes
to,
away, and maybe
to assess the
could
situation and stabilize.
have,
it until
you know,
medical
3 or 4
transport
health
can arrive.
aides versus.
And so,
if you
which is
didn't have
often a
that,
helicopter
you would need more.
in that part of Alaska.
Um,
But that's
so
like, in
certain
Kentucky, we don't
providers
need that, we're on the road system, so we don't need them to do emergent care, so we want them to do stuff like this chronic disease management, elder care. And really
certification
like
level
filling
of
in
the
the
providers.
holes of where you don't necessarily need an advanced
so-
practice provider, but you could use a primary care provider in that.
I'm trying to think what's a good
One
question.
Earth had done a evaluation program.
So probably, I mean, in between a CHR and a licensed provider, and that's, this is all brand new, I mean, this is something
So she would
for our
be the
area,
person
that one, we're actually having to build certification program,
And then they
building
incorporated
curriculum and introducing these new provider types, so, I mean.
When you say provider. So it kind of sounds like what you're talking about.
Yeah, I mean, we talk about it a lot, it's like there are many.
Yeah,
levels
so
of
when I'm
care
saying
needed
provider,
within,
yeah, and that's the
like,
thing is
any
that
patient
health aides
population.
are not
And so really
providers,
relieving the
they don't have,
pressure on
they're,
your
they don't have
advanced providers,
certifications,
but
they
they
don't have
really
a
can
license,
at the
right?
top of their
Their
skill.
certifications, so
And
they'll go
the
through
sort
that
of
process, but when I say
and then with
providers,
your-
yes,
we like to call them
it's your nurse
provider
practitioner, physician,
you
your
can really
dentist,
just
or
build out that primary
therapist,
care level of care,
I can't remember the behavioral health.
and so the
supervisor,
areas
but-
that are tribes
But yeah,
identified.
so
this
those
is
are the
chronic case
providers and,
management, chronic
so
care
those are the ones that
management,
will have the
pediatrics,
health
chronic
aides
kids,
under,
and then
practicing under
the
their license.
well
right?
woman,
Which is.
well child, well man visits, you know, kind of all of that primary level of care. And then their doctors, there's a limited number of doctors that can provide that care. And also it helps with the turnover too, because your primary care provider is that health aide who's gonna stay on, stays in your community. And then as a doctor rotating, you still have that primary care relationship
That's how I started, or this new job.
And it's the same in dentistry, like we have a mental health therapist who was working at the program with Swallow Tribe. And when they had this totally insane. And I mean, to the point where the entire staff, like.
So I know Northwest Collaborative program, it's hybrid, right? So they do, I think there's a portion that's online.
And
they
when
do
you left
their
the.
program, but then they do like clinicals or like, you know, in person.
They told their retired dentist.
Through their
and
partner
They were like,
clinics,
hey,
travel clinics.
we're in this situation.
So.
We just got rid of this super toxic dentist, but we know you're retired.
So
especially
and the thing, how they're rolling this out is they are, because it's gonna look
He
different.
said,
it
yes,
should look different
pandemic,
every
and
year,
she
yeah.
carried that.
And so that's why they're starting with this systemic kind of phase, it's like,
But in that
okay,
time.
taking Alaska's directive program.
And then all of like, they don't,
You know, how
so all that
and
stuff, they
and going through
send
these
out, but
assessment
all of that
activities,
primary care, they
talking to your community, you know, how do you, how
So there's just a lot of ways
and really making
like
it, making it your own based on the community, so,
people in the clinic.
yeah, like the,
Times when
they are,
providers do this all the
their
time.
certification programs, but I was into your question earlier about what's
But
like
they
the
do, and then
equivalent.
you have.
So like for dental, I think like in dental health, like level three.
Are you continuing to have a discussion on this same slide?
Yeah, we may not have the answer before.
But in terms of like
But you can move to.
the difference between PHR and the CHAP is that CHAPs are, they're providing levels of.
Yeah, and this actually
Whereas
is a little.
PHRs are
Right?
more
And it depends on what level, this is a hard question. to
education,
answer. I think
conventions,
clinical level and
CHAPs are too,
and they're
but they're
really
have
some of that area
certifications to be able to provide a
might be
certain
more
level
on
of
that area
care.
level implementation.
So like they can do,
And one of the big.
so for
decisions
CHAPs,
for
they
us
can
is
do
that
like
clinic
checks,
level
they can
implementation, what that looks like,
blood pressure, you know, and we have, and I have some slides that have. A
You know, we
list
really
of all
think that
the,
our.
based on Alaska's model, what a CHAP one can do, what a CHAP two can do. And so in all of those procedures that are listed under sulfate, are, you know, they're all, and what's all, and we haven't really talked about it much in my session or here, is that it's not what's called the can, and it's digital.
A lot of because we want all the writers to get in the clinic, what we find.
They have
they're the best at it.
that five step
And they.
of like,
They provide.
kind of
care.
where
It's
they
also
say,
really
very, all right,
good
this is the problem, this is the
dental
concern of
therapist,
the
like,
patient,
okay.
these are the
You know,
things.
it's so hard to hear through your own.
And it's
like,
intended that.
she likened it to being like the council, right?
Intended
You know,
to
it's
mirror, or it
all the
should
things
mirror
we're trying to
your
clinic and they're asking for.
Health.
Right? Really,
So.
situations might have your house position.
We haven't even got to ours.
Sorry.
No, no, I mean, there's always more questions that are.
Really,
Be able to,
like,
it's just, it's so obscure right now because.
There were two dental therapists, like,
It's-
the other one's a bit older. It's more like, she, you So, it's a pretty short training program at the lower levels, and it's all together. We're training between the didactic and clinical training. There are 4 different levels. And so really, if you have graduated from high school and the basic training level, you can start the program. What we're doing in the partner area is quickly, one, we're working with CHR programs to uptrain CHRs to become CHR levels. The other thing we're doing is we're really targeting people who are like this is low hanging fruit, people are already in the clinic and maybe your front desk person, or maybe, you know, one of your medical assistants from the back. And expanding that sort of practice.
I know, I think
We're furthest along in process is, we did, some people we just started and told were like, you would be good at this. And then it was really like, it was the students who had experience in the dental clinic or in the medical clinic that had the most.
so, like, going
They
through,
couldn't have such a.
you know, so even like having a survey, going into, so going into the book, you know, and trying things, they were. The survey that was created based on the. Infrastructure. And everything. And I'm having to share the survey.
There's a have to be somebody who's in your.
But that way, whenever you get those results.
It could be.
Not in what what's the focus, right? So based on
Anybody can do
on
it.
the type of care, and
I
the
think our
gaps
process on the
that are
units are-
identified, it's like, okay, well, you know what, we're seeing a lot of,
To our region,
you
but,
know, acute.
but I will
care
say the one thing that
needs.
we found is our.
And so
report, they just
maybe
got more
that's
support
gonna help inform
than
me, okay,
online cohort.
at the level of
They had-
information that we got, you know,
Easy.
we're gonna focus on.
We gotta go with
the program first, and let's start with five.
And when Martha
that
comes
work
back
our
to
way out,
you,
or something, you know, and so that's why I think that.
You can go back and figure about, like, what is this in our thing? What is-
Ultimately,
Yeah,
And
that's
you can pull out.
that's the goal, yeah, because there's no way it can be.
We all kind of know what we
sustainable
need.
without.
Oh,
we're gonna. We're gonna. My group's. We're not answering any big questions. Like, we usually have more questions than we have answers to your questions.
Let's go back.
That's right, I got it. Oh, no, I say, I have questions.
Group one, if you will, it'll be group two. If you will, give us a response to question number one. What were you able to gather from the conversation? Really good dialogue going on. I could hear the conversation.
Oh, go ahead.
I think for me, I'm just kind of learning about this and I work in the diabetes unit. And so, and I know the medical unit really well too. And just as for one thing, it's like I see podiatry is a big need. Like we have one podiatry doctor and she's overwhelmed, like she's booked into October already. So I feel like that would be a need for my clinic. I mean, there's lots of need. But that's one that really kind of comes to my mind right off the bat.
We talked a lot about kind of setting the groundwork for how to answer these questions. So when you come back, Martha, with your official survey, really, it's about thinking like what we talked about is like, what does your clinic need and how could expanded workforce fill those needs?
That's a good one, podiatry. That is, sounds a lot like my community. That is, wound care and saving that limb. with Diabetes patient is where community health health aid would really be beneficial to that patient. Anything else on number one?
So we had a lot of questions, more questions about the question, and they were great. So one thing that was brought up was what is the ratio of health aides to provider? So that was a really great question. Because how do you know how many you need if you still need to identify that provider that will be supervising them?
I was thinking as y'all were responding, you're in a different setting, right? You're a organization, tribal organization where you serve multiple tribes.
Yeah.
So your staffing needs are different from the tribal setting.
Right.
And I was trying to think of, well, how many staffers does Julie have? To the to the population that she serves. So related to the population base, number one, it's not gonna be, it's not a one size fits all. It's gonna be based on your population. And,
And I think that, another thing that, the disconnect between, headquarters and some of the information there is that some of these things are really nuanced and that these questions are really, well, it depends on this and this and this and this, right? And so it's hard to say, at least for areas where we're still kind of discovering, what that's gonna look like for us. So.
so when we make our budget justification, there's data, that's needed and comparative data
Yes,
that you need.
yeah.
Question number 2, identify systemic barriers. The lack of experience to identifying what that clinical infrastructure need is, right?
Right, transportation, is a significant barrier. We're also talking about, the need for translators, and what you're talking about schedulers. So like for some of these rural remote areas that don't, and our elders that don't have cell phones and don't have, those type of supports is that, is looking at those at those barriers and identifying ways to incorporate supports.
Anything else on 2?
I was asking about the certification of providers. What, is there someplace that you would be able to read about that to see what that
read?
is? Well, it says, to prohibit to complete the chat into an existing health system and what type of certification of the providers would you say that would require?
And that's what those subject matter experts in the sub-work groups of the National Certification Board are going to determine what that criteria is. And that certification, to answer your question, will be signed off by Dr. Cotton, your area director. But based on the recommendations of the certification board of the providers that's submitted to the certification board. And of course, there's the training of providers. I think those early programs. Now you're cutting me off. And then just the inclusion of the culture, and those at the tribal setting are the best at that. And then estimating staffing needs, we've talked about that. It depends on your population base. And that's a very good question of the health aid provider to the ratio. And then the planned partnerships, we kind of talked about it throughout the presentation, your state, CMS, other grantees have been in your state. But that's all that I have. Thank you for your feedback and that means I will till we meet again. That is my huge effort to revitalize our language. We lost so many speakers during COVID. So I'm doing my little part here to revitalize our language.
Thank you, Martha. Appreciate you. And also, Christine, just and Julie for talking about chat. So Martha, USET has a gift for you for presenting.
They always
Thank
give
you.
good gifts. I'm excited.
And also, do not forget to complete an evaluation at the end of this session that will be emailed to you. The more evaluations you fill out, the more times your name gets entered to win a raffle prize that is going to be happening minutes from now in the main ball.